Welcome to the Cancer Neuroscience Symposium Conversation Series. I'm Monty Montano, Executive Editor of Wiley's Advanced Portfolio. We're excited to partner with MD Anderson and host this series to hear from key speakers featured in the February 2026 Cancer Neuroscience Symposium. Thank you for tuning in as we explore ideas to advance cancer neuroscience together. Welcome, Nicole. It's so nice to have you and to see you again after the last conference. We're super excited about the 2026 Cancer Neuroscience Symposium. And the way we like to start these conversations is to learn a little bit more about you, the person, the Nicole. And I guess it would be really interesting to know how you kind of arrived at cancer pain as a topic, as a focus of research in the context of neuroimmune interaction. So was it while you were a postdoc or a grad student, or what sort of events led you to sort of focus on this super interesting area?
Sure. Yeah. Thanks so much. I'm happy to be here. It's a good question. I think I might be a bit unique in the trajectory a little bit. As Kinsey pointed out, my graduate work was looking at the plasticity of the primary afferent in the context of inflammation and sort of how primary afferents shift how they handle intracellular calcium during persistent inflammation. And while interesting for a graduate project, to me, I couldn't tie the clinical relevance to it. When people would ask me what my research was on, it's so granular and you can't really relate it to anything medicinal or clinically relevant. And so when I was finishing up my graduate work, I wanted to shift gears and do something that seemed like it would affect people more than sort of the mechanistic work I was doing in graduate school. And there was a colleague in our Pittsburgh Pain Center just down the hall from me who was studying pancreatic cancer pain. And that's Dr. Brian Davis. And so I was sort of peripherally aware of the field of cancer pain. And when we were looking for a postdoc position, I thought that seems clinically relevant. And so maybe I'll study that. And my husband wanted to go to New York. So I looked for a postdoc in New York and I met a guy who was doing head and neck cancer pain. And so Brian Schmidt, who I did my postdoc with, is a maxillofacial surgeon, and he had a basic science lab. So he saw patients and then saw the clinical problem, the pain associated with head and neck cancer. And then he had a basic science lab to understand the etiology of that. And that to me seemed like the perfect fit. And so I joined his lab and sort of started to learn a lot about how the primary afferent changes in the context of cancer.
Super, super cool. I mean, just how, the serendipity of the environments you're in and who you meet can really influence the kind of work that you do. You mentioned inflammation, and inflammation can feed into pain along with, mechanical and thermal stimulation, chemical stimulations. Mm-hmm. So it seems to me like there's a clear connection there. But what I'm trying to wonder about, or am wondering about, is how do people measure pain, given that there's both a subjective part to it and also an objective part? So what sort of tools are you using to sort of quantify pain?
Pain and the two ideas. So as a peripheral neurobiologist, we really differentiate the perception of pain and pain as a body experience to nociception, and nociception being the peripheral detection of a noxious stimuli that is then transmitted centrally to the brain. And so nociception is the peripheral signaling mechanism, the neurobiology, and then once it gets to the brain, that's the perception. And so there's different camps in the pain field in terms of how people study the idea of pain neurobiology. And I was trained at the University of Pittsburgh, where they're very much afferent focused. They're focused on the primary afferent system, with a lot of these chronic pain disorders or issues in the body in which when you remove the primary afferent input, the pain goes away. Mm-hmm. And cancer pain is really one of those factors, particularly prior to treatment. If you remove the tumor, most of the time the pain goes away. And so that sort of suggests that primary afferent drive from cancer activating the primary afferent is that source of pain. And once you get rid of it, the pain goes away. Now, there's a lot of other things in survivorship that shifts that idea, that now that you've done this massive resection, there's a bunch of post-surgical pain that occurs, and that could become chronic and lead to downstream issues. But we really think about nociception before it hits the brain as the primary focus.
Super interesting. I'm just wondering, just thinking about nociception signaling and sort of in the context of tumor formation. I mean, nociception it's a normal process, right? It's how somatosensory neurons, report on noxious stimuli. So, in the context of a tumor, are those signals being amplified? Those normal signals being amplified, or are there new mediators? How is the tumor changing, amplifying, creating chronicity, I guess, of the pain signaling cascade through nociception?
Sure. Yeah. That's a hard question. That's something I think I grapple with a lot in my work now, that sort of straddles the idea of cancer pain versus the impact of the nerve on the tumor microenvironment. A lot of cancers are not painful prior to treatment. And so what I found most exciting about head and neck cancer is that it is painful so early. Patients present with pain, and that's how they get diagnosed. So that communication of the cancer amplifying or activating the nociceptive afferent was sort of right there pre-treatment. Cancer like breast cancer, even pancreatic early stage, late stage is a different story, but pancreatic, melanoma, these tumor cells release a lot of the same mediators that head and neck cancer cells release, but patients don't present with pain. That's not how you find out that you have those diseases. And so I think that is super interesting to me. And it seems like some of the work I did in my postdoc suggests that the immune system could be a source of endogenous analgesia, or there are mechanisms in the tumor microenvironment that could sort of silence the primary afferent to the point that it's not propagating signal centrally. We know there's a lot of inflammation with cancer. And like you said, inflammation is linked to pain, and inflammatory mediators, we know interleukins, TNF alpha, all activate the primary afferent, and pain is associated with that. But in the presence of cancer, you have this inflammation, but it's not driving a signal centrally. And I think that's so interesting. And there's a potential there that if we can identify the reason why some of these cancers aren't painful, not that we want to make cancer patients experience pain, but if we could figure out what that is, maybe could be a biomarker for detecting cancer earlier on.
Super, super interesting and very translational in its potential impact. When you think about these mediators, I mean, they can be soluble lipids, I guess. They could be proteins. They could be extracellular vesicles that contain all sorts of stuff.
Yes.
So, are all of those part of your research program, or are you focusing on certain, key potential
Yeah.
biomarkers?
So that's a super great point, and I think it's something that is missed a lot. Again, maybe flaws in the cancer field itself. I mean, the cancer pain field. But as much as I appreciated my time with Dr. Schmidt in his lab, a lot of the work he had done early on, now his program sort of switched, but was exactly that, going in and cherry picking mediators out and saying, okay, cancer cells release ATP. Can ATP activate a neuron? It can. Can we go in and block ATP? We can. When we do that, do we reduce the pain? We do. Yay. And then we move on to the next mediator, whatever that is, proteases, prostaglandins. And so showing up to his lab was sort of like, wait a minute, you're like semi-curing cancer pain with each mediator you target, but the other ones are still there. And so how do you grapple with it holistically? And I think those sort of questions were the reason why when I was writing my K99, it was like, we have to think about this a little bit more globally. And like, what is inflammation? It's like inflammation is part of the immune response. It's like, okay, what are the immune cells doing? And it was like asking those questions from the neurobiology perspective that made me realize I need to learn more immunology, because it's not as simple as the cancer pain people have painted it out to be, where a macrophage is the only immune cell that we talk about.
Right. And I guess
And
the
so I think that's changed
TME,
it.
people are beginning to recognize the TME is, there's a lot of immune cells in there.
Yeah. And they're doing different things.
Right. I mean, it speaks to the heterogeneity of that microenvironment. and whether different cancer cells within the tumor microenvironment are secreting different types of factors
Right.
that either amplify a pain signal or maybe create diverse pain signals, I guess is the question.
Yeah.
But when I think, and Kenzie, jump in if you have a burning question as well, but when I think of pain and cancer, I think of, the treatments that are often, offered, and those usually are opioids. But I think that opioids, and I think you've done some work on this, they have immunosuppressive properties. And just curious, Nicole, what are your thoughts about new modalities for cancer pain treatment that don't include opioids or are an alternative to, I think, a lot of the adverse effects associated with opioid treatment for
Yeah,
cancer?
for sure. It is definitely a project in our lab is thinking about the analgesic strategies we have. I collaborate a lot with medical oncologists, and I have a tight collaboration with the director of our survivorship center in head and neck cancer at Hillman. And we talk a lot about, she cares a lot about what happens after the patients go through treatment and these chronic issues that they have during survivorship that she's trying to alleviate. And I like to look at things at the pre-treatment standpoint, something that I can model in a mouse and say, can we use that pre-treatment data to predict what sort of survivorship they'll have? And we came across the level of opioids that these patients are on because it's quite clear in the literature that pain is a poor prognostic. Pain means tumor aggression. The patient needs to have analgesics on board to reduce stress. They're going to stick to their treatment strategy better when there's low pain. And so they sort of throw opioids on board pretty early to sort of keep things at bay. And we've known since the 90s that opioids are incredibly immunosuppressive. And that information sort of fell off as we move into the world of immunotherapy and checkpoint blockade and this idea that we can reactivate the immune system to fight the cancer. And then we forgot that all these patients are on opioids, which is sort of inhibiting that response. And so we've done a bunch of work retrospectively in patients and then modeling in animals why opioids are immunosuppressive and what that mechanism is. And it seems to be that the infiltrating immune cells actually express receptors for common opioids. And so that immunosuppressive factor is actually peripheral. And so one option in order to maintain analgesics with opioids, which we know work fairly well, at least in a decent population of patients, that we can put them on a peripherally restricted opioid antagonist. So methanoltrexone is already FDA approved for opioid-induced constipation. So there's already a peripherally restricted mu opioid antagonist in the market that we can use to counteract that opioid-induced immunosuppression. You just have to give them at the same time. And so we've done a bunch of stuff in mice to look at that, and then trying now to get a small clinical trial going, which is very low risk. It's just bringing the patients in and prior to immunotherapy, putting them on this peripherally restricted antagonist with like a 2-week lead in to see if it improves response, just to sort of counteract that opioid-induced peripheral signaling. So that to me is the best option currently, because it's going to take a lot to move the needle in terms of how the medical oncologists are treating pain. One of my primary collaborators for the patient part of that is a medical oncologist who treats recurrent metastatic head and neck cancer patients. And he knows the data that shows that opioids are immunosuppressive, but it's still hard to get him not to prescribe it because you see the patients and they're in pain and you want to do something, and the only option is what he has. And so that's frustrating for me as a basic scientist. It's like, just stop treating them. Tell them to suck it up. Put them through but you can't do that. So now trying to look at what else we could use. And I think the recent literature in cancer neuroscience is really starting to suggest that targeting the primary afferent and targeting its signaling may reduce pain as well as improve the immune response or actually slow the tumor growth in some way. And I think it's fairly low risk to target the primary afferent. Like worst case, the pain reduction isn't much, but you might get slowing of the tumor or something along those lines. But that is the primary source of propagation for the perception of pain. So it might be worth targeting. And the methods to do that can be Botox, which is FDA approved, as you can inject in the right site. A lot of these I think about because of head and neck, so that's a little bit easier for the trigeminal system to use Botox. But there are new mediators coming out to target the sodium channels that are specifically on primary afferents, so 1.8 subtype, that could actually work for this. Even like low-level lidocaine pumps could be useful, like a local block.
That's interesting, the concept of low level and dosage. And I just wonder about whether, you know, the prescriptions are just too high. There's just too much. And I, as a cyclist, we often say no pain, no gain. I mean, you say that for a lot of exercise. But I mean, the hormesis theory is that you need a little bit of some sort of, adverse stressor to build resilience. And I just wonder if maybe, as you said, maybe a little bit of pain might be useful. And some people use it as a measure of performance and a measure of progress. In the context of cancer, I'm guessing there are probably different strata of society that sort of interpret and can handle pain differently. And I'm guessing, as I recall, you've done some work looking at differences in pain tolerance that exists between, biological males and females, men and women. And could you speak to that sort of heterogeneity in pain tolerance in the human population, and what that might mean for pain signaling and clues for maybe personalized treatment?
Yeah, for sure. So we did look at sex differences, biological sex differences, and when I was at NYU with Brian Schmidt, and then we did again when I got to Hillman, because they had a bigger swath of retrospective data that I could leverage, and it held up, which was sort of nice. I haven't thought about it as a tolerance issue. I think of it more as, again, because this is the way I was trained, this is as a primary afferent neurobiology issue. If you're having less pain in one biological sex versus the other, maybe something's different in the tumor. And so we initially did some studies looking at infiltration of neutrophils into the tumor microenvironment. And we looked in mice initially and sorted those neutrophils out and saw that they can release beta endorphin. And we found more neutrophil infiltrate into into tumors from male mice than we did females. And our male mice are able to complete these tasks that we put them through, suggesting that they have less pain. And so we sort of linked that neutrophil infiltration and beta endorphin release in the tumor microenvironment to sort of shutting down the primary afferent. And so they don't feel as much pain when they're trying to complete this gnawing task we asked them to do. We looked in patients and we saw some differences in neutrophil infiltration. However, this is right when I was transitioning into my independent lab. And Bob Ferris, who is the head of the Hillman Cancer Center at the time when I started my lab, is an immunologist and a head and neck surgeon. And we talked a lot about whether this is a viable approach of looking at neutrophils as a way to reduce cancer pain. And I learned a lot about immunology in that first little bit, and this idea that neutrophils can become pro-tumor, and this is the part of the innate system. And if you're going to drive neutrophil infiltration into tumors to suppress pain, it's probably going to make the tumors worse. And so we sort of dug into my mouse data, and lo and behold, I wasn't looking at the tumor microenvironment well enough. And you see in the mice that I drove neutrophil infiltration, the tumors actually metastasize more and spread down the tongue. And I was like, oh, that's not good. And so we sort of went back to the drawing board and looked at the other immune cell types to sort of see if we could find another immune cell that we could leverage to treat cancer pain. And this is now a collaboration with Sebastian Talbot, Karolinska Institute, where we're looking at B cells and the ability of B cells to release endogenous opioid. And that sex difference is still sort of held up. The issue is the prevalence of head and neck cancer is much higher in men than it is women. It's like 3 to 1. And so it's really skewing our data sets. And so we're having to take that into consideration as we look. What's more interesting to me, and it's worth me going back and looking at my data from NYU, is the location of the tumor for head and neck cancer and how that differences in pain shows up. So there's two main types of head and neck cancer. One is carcinogen induced, so smoking, alcohol, carcinogen exposure to the oral cavity, and the other one is human papillomavirus. So HPV can drive oral cavity cancer, but the site of the cancer is usually in the oral pharyngeal region, so the back of the tongue or the tonsils, and that type of head and neck cancer is not painful. The patients complain of issues with swallowing, but they don't necessarily present with pain. And so we certainly have all had sore throats. You've had people complain of pain with tonsillitis. So we know that you can experience pain back there. We have innervation back there, but they don't report pain. And so I'm really interested in sort of understanding how the primary afferent plasticity occurs between those two cancer types, to look and see what that activation is like, whether it's the tumor itself and the viral signature within the HPV-induced carcinoma, or if it's something about location. To your point, I haven't really thought about perception and what's happening centrally. I try to stay out of the brain. It's complicated up there. I like to stick with my one neuron. But it certainly could be shit, like in terms of perception and motivation to survive despite the pain could certainly be a part of it.
Super interesting. There's so many questions. I could spend a whole day. Kenzie, I wasn't sure if you wanted to jump in, but if not, I guess I wanted to go back to the neuroimmune interactions and also the neutrophils that you were just mentioning. So, does the tumor in any way modify neuronal modulation of immune cells, like neutrophils? Is that something that you're looking at, that there's neuromodulation of immune function, and that the cancer skews that in some way? And is that true in head and neck cancer in a way that's different from, say, breast cancer or other types of cancers?
Sure. I haven't looked at neuroimmunity in the context of neutrophils yet. We sort of let that die when when my boss told me it wasn't a good idea to study neutrophils anymore. But certainly neuroimmunity and how the primary afferent has been known to be an immune modulator in the context of inflammation and cancer pain for a while. We know that you get release of neuropeptides. When you get activation of the pain neuron, as that signal propagates centrally, you also get release peripherally of neuropeptides. And those neuropeptides, CGRP, substance P, VIP, have been implicated in neurogenic inflammation. And what this term is basically the release of these neuropeptides is driving an immune response. It's been mostly characterized with macrophages. So when you get the release of this neuropeptide, it activates macrophages, and you get this inflammation that was due purely to activation of that afferent. What's come out in the last 4 years, is that not only does it activate the innate immune response, and you get this neurogenic inflammatory response with macrophages, it also suppresses the adaptive. And so there's been some work in the wound healing field sort of looking at this balance of how the pain neurons in the presence of a wound will help activate the immune response to treat that wound. And then you get release of mediators from those immune cells that sort of shut the afferent up. And then you get the adaptive that come in and clean everything up. And cancer we sort of consider like a never healing wound. And so you get this chronic innate immune response and the suppression of the adaptive. And that's a major problem when thinking about trying to get cytotoxic T cells and NK cells to fight the tumor if they're chronically being suppressed. And so what we don't know is if activation of that primary afferent to the point where you perceive pain is needed to get that neuropeptide release. And this is something that is incredibly hard to study and also is being grappled with in the field of pain for a while now. What does it take to get neuropeptide release? And this idea that the CGRP and substance P could be suppressing the adaptive immune response has come out in the literature quite a few times now across different journals and across different cancers. And some of these cancers are not clinically painful, one of which is melanoma. And so if there's no perception of pain in these animals, they're not limping, they're not favoring the leg where the melanoma is, then are you getting CGRP release? And it looks like you are, because in these mouse models, if we target the CGR signaling pathway, we're able to modulate the immune response, actually activate that adaptive immune response again. And so it looks like maybe you don't need pain. And I think that's super interesting when we're thinking about leveraging neuroimmune interactions to treat cancer. When we look at the clinical population, what could we say in terms of this patient is a good candidate to target the immune system target the nervous system to improve immunity? And that we just don't have enough information for yet. But it looks like maybe pain isn't necessary. It certainly doesn't hurt. If you have pain, you probably are getting neuropeptide release, but it might not be required.
It's just super interesting. I wanted to come back to this idea of cancer as a wound that never heals. And in the context of pain, I just wonder, when you think of wounds, you think of like fibrotic scar formation and fibrosis, and that becoming sort of a barrier in ways for immune infiltration. Is there any association with the potential scarring or fibrotic tissue formation in the TME? Is there any association with that fibrosis and pain? Is that a marker that could be radiologically used to anticipate chronic or acute pain?
That's a really good question. There was a recent paper, I can't remember whose group it is, that just looked at cancer-associated fibroblasts and the CGRP ramp1 mechanism and natural killer cells, and sort of looking at this interplay between the peripheral nervous system and the pancreas and cancer-associated fibroblasts. I think in terms of wound healing, when you get that fibrosis or that like matrix to help with the wound, we know that with the wound, you also get dieback of the primary afferent and injury of those afferents because they also get damaged. And so then you need mediators to help reinnervate that area. If you think about a paper cut that takes forever to heal, but you've also severed that innervation from those neurons. And so they need that callback to reinnervate. And it does reinnervate and heal, and you don't have permanent soreness in that spot. Everything goes back to normal. And there's certainly a neurocentric mechanism there where if you injure the neuron, you drive transcription factors, ATF3, SOX11, that then drive a descending mechanism to instigate growth cones and resprouting. But you also need mediators in the environment to tell the neurons where to regrow. You can initiate that growth cone sprouting, but they need directions. And I think these fibroblasts are a good mechanism for that, where they'll release nerve growth factor as a call to say, okay, this is the area that was injured, you need to innervate here. And so I think it's that interplay where you're getting release of these growth factors to help that reinnervation. And then the context of cancer, the cancer cells release a lot of NGF, particularly cancers that have already gone through the mesenchymal transition and are a little bit more metastatic. They release a ton of NGF. And so that's a potential mechanism to target. Is like, okay, they're calling in these nerves saying innervate here. And with that innervation comes immunosuppression. Thinking about it from sensory, from sympathetic, it's the same. They're calling the sympathetic efferents in. And with sympathetic innervation, you also get angiogenesis and formation of blood vessels, immature blood vessels, and food for that tumorastic growth.
I guess I want to ask about what are some of the techniques you see becoming important to answer outstanding questions in cancer neuroscience? What are some of the future directions you see the field taking?
Sure. I think the spatial transcriptomics and spatial proteomics are going to be hugely important. My lab isn't currently doing them, but I can see in the future that becoming critical in terms of the nerves don't innervate cancer in a systematic way. It's not somatotopic. They're just, I mean, it depends. And the bigger the tumor gets or how metastatic it gets, these sites are different. And so as we, as cancer neuroscientists, take a piece of that tumor and look at it, that's just a snapshot of an area. And so the more we can integrate these ideas of being able to look at how the immune system is in proximity to the nerves, neural niches, looking at how nerves interact with germinal centers and tertiary lymphoid structures to sort of understand maybe you only need to de-innervate this area, or maybe you can target a certain type of immune cell based on its proximity to the nervous system. So I'm excited about that. And hopefully the cancer immunologists will sort of let us infiltrate, for lack of a better word, and start to optimize some of our neural markers into their panels, because they've done a great job characterizing these immune panels, but we really need to optimize the different nerve subtypes as well. And so I can see the field sort of adapting to appreciating the different subtypes of nerves that innervate, appreciation of the neuroanatomy, particularly in visceral tumors where you have vagal innervation versus somatic, and vagal encompasses majority sensory, but you have a subpop that are parasympathetic. So as you mess with vagal innervation, you're messing with two different types of nerves. So I think that all that's getting better in terms of our techniques. As you see the literature sort of evolve, people are getting more careful with what they're looking at. What other techniques am I excited about? I think that we're actually getting better at translation as well. Early on, it was really just crude mouse models where we're cutting the entire nerve and saying, look, things changed. And I think that we're getting more leveraging a lot of those neuroscience technologies like dreads, where you can virally drive a unique channel that's activated by light, or a unique channel that's activated by a unique ligand, and actually push and pull the nervous system to look at it from both angles, right? Instead of just cutting it and saying it went away and things changed, actually driving nerve activity and seeing it getting worse, and then suppressing nerve activity and seeing improvement without actually de-innervating and changing the structure of the tissue. And so I'm actually excited to see that infiltrate better. And as a neuroscientist, I think the neuroscientists are actually getting better at appreciating cancer immunology for what it is, and how we are not going to cure cancer by targeting the nervous system, but we can certainly help. And so I think that the more appreciation of cancer biology and everything that they've done to date, and then how we can sort of fit our niche into that and not just discount it completely because they didn't consider the neuron.
You know, the really cool thing about this field is that it kind of requires breaking down silos, right? I mean,
Yeah.
cancer, the immunologists, you know, the neuroscientists, you know, the bioinformaticians. You really have to be prepared to walk down the hall into other departments and forge these collaborations. And
Yeah.
I'm just wondering, Nicole, can you sort of speak to like the next generation of scientists, and you know, based on your experience, you know, what should they, how should they prepare for this type of work? Because I think this is becoming more the rule than the exception, that we have to cross disciplines, because typically diseases are not a single organ. They're not in isolation. They often are systemic. Holistic approaches are clearly uh, the better representation of disease phenotypes. And so just sort of becoming comfortable with, you know, that willingness to explore across, you know, academic landscapes. How should, you know, grad students like Kenzie and others, you know, postdocs, uh, what advice can you provide them, give them as you sort of navigate these very same halls?
Yeah, for sure. I think so I have two graduate students in my lab, and one's in his third year and really needs to propose, and then the other one's brand new. And I think as I'm as I'm developing or together, we're like developing their committees. I think having a committee that's multidisciplinary is huge. I mean, I think to date, most people just pick people within their tight, like you said, silo to be on their committee, and then it becomes an echo chamber. So I think in putting together committees, we need an immunologist, we need a clinician that does the disease subtype to get their perspective. And I think that's going to be super useful. It might make his life harder because they're going to have to explain all facets to all the different people in the room. But that's going to force the project to be more translational. And same with postdocs. I think you can surround yourself with mentors that go from each discipline. It's only going to make the work better because you have to state your case for the mechanism to each specialty. Because there's no way that we can have PhDs in cancer biology, immunology, and neuroscience, but you can have experts on your side to sort of help with that. And I think same with training grants. As we submit those, they should have committees that are multidisciplinary. A lot of these R01 grants need to have a translational aim, or at least the idea that it could go it could translate, whether it's from neuroscience into cancer immunology. That's a fine translation. It doesn't have to go to people, but just to show across the scope that you have expertise. It's not just within house. Because I think stuff does get stuck in an echo chamber where you believe this mechanism and you just tell your tight group of people, and then it becomes fact, and it actually might not be true. Until you have that immunologist come to your poster and it's like, no, like, oh, shoot.
Excellent. Well, I wanted to give you a chance to plug your book also. I know that you wrote a book with Moran, I think it was like a couple of years ago. Is there an update? What are we going to hear at the 2026 Cancer Neuroscience Symposium?
Sure. Yeah. It's good. I think we just talked about it. He and I feel like we edited. We didn't write. We edited. Everybody else did great writing. I feel like we did it in 2020, but I don't think it actually happened until 2022. So it's only been 3 years, which isn't long enough. But it's certainly the 5 year point. We'll look for the second edition. I mean, so much has happened in this field. It's moving so fast. So it's clearly, we probably could write an update now, but I think let's see how things shake out. Yeah, when he and I edited that book, we didn't even have the CGRP immunosuppression story yet. That wasn't in existence. And so that just goes to show since then there's like 8 papers looking at the CGRP ramp 1 axis. So there's a ton that we could do. And it's exciting to see what will be next in terms of how the field's moving. I think he and I need to touch base. We talked a couple months ago. We were like, oh, we'll wait. But who knows? With Moran, it could be tomorrow.
You're certainly going to get a chance to talk at the Cancer Neuroscience Symposium, and we're very, very excited to hear about your ongoing work and some of the stuff that you hinted at but haven't will be sharing, I guess, at that symposium. Thanks for tuning in today. We hope you'll join us as we continue the conversation in Houston and virtually at the 2026 Cancer Neuroscience Symposium hosted by MD Anderson and Wiley's Advanced Portfolio.